and then two of our excellent fellows, Dr. Brian Go and Dr. James Burnetz. Today, we're going to be kind of doing a little bit of a different focus. I know we focused on a lot of surgical topics in the past, but today I think we were kind of interested in maybe talking a little bit about some of the more popular pain procedures that have come out, maybe looking at what the evidence is behind them, and hopefully we can kind of get a good discussion going. Jim, Brian, you want to kick us off?
Yep. Virtual Spine Journal Club, and it is a fantastic topic that Drs. Sebastian and Nasser have selected. Very much near and dear to our heart, as I just had clinic yesterday with multiple patients having interventional pain management issues. Interventional pain procedures, what's the actual evidence? So without much further ado, live from Rochester, Minnesota, Dr. Sebastian and team.
Very good. Thanks so much. Can everybody hear me?
Sounds good.
Yes, great. All right, my name is Jim Burnetz, one of the orthopedic spine surgery fellows here at the Mayo Clinic. I'll be starting things off this morning. This is an article titled "The Effect of Spinal Cord Burst Stimulation versus Placebo Stimulation on Disability in Patients with Chronic Radicular Pain After Lumbar Spine Surgery." So a few reasons why we wanted to pick this article. One, it was published in JAMA, so anything about the spine published in JAMA should probably get our attention. It's a recent study published in 2022. It's out of Scandinavia, out of a large center in Norway, and many of their trials have excellent methodology, and I think something we can learn from. And finally, this is a problem that we encounter on a daily basis in our clinics. These are patients who have already had spine surgery that are returning with chronic radicular pain, and it's thought that we don't have any other further surgical benefit to provide them. So this is a great population to look at. So talking about spinal cord stimulation, this is a pretty big industry. 50,000 patients annually get spinal cord stimulators placed worldwide. And it's a big money industry, $2.8 billion. But it's an industry that's backed by pretty limited evidence. Most of the studies you'll see are very biased. They're company-sponsored, company-specific implants and types of stimulation. So the data on this really isn't great. This current study is comparing a mode of stimulation which has come out relatively recently, which is burst stimulation. So previously, the idea behind spinal cord stimulators was that you stimulate the nerves and you turn their pain into paresthesia. So they know that it's on because the pain goes away and they get a paresthesia in that distribution. But with this burst stimulation, you get trains of closely spaced high frequency stimulation that actually don't result in the paresthesia. So patients can't as easily tell if they're being stimulated. So this allowed them to do a randomized blinded study. So their study question was, among patients with chronic radicular pain after a lumbar spine surgery, does spinal cord burst stimulation affect back pain related disability? This was a single center quadruple blinded study. It was placebo controlled and the patients served as their own controlled, and it was crossover randomized. They included adult patients over the age of 18 who had had a previous decompression or fusion, and then more than 6 months postoperatively continued to have radicular pain with a minimum score of 5 out of 10. And their methods say that there was, quote, no additional spine surgery or pharmacological treatment was assumed to be beneficial. And then I really like their exclusion criteria here. They tried to rule out patients that you wouldn't really want in the study. Those who have had a previous stimulator, had abnormal pain behavior, had comorbid psychiatric illness, were thought to be looking for secondary gain, or had inappropriate medication use. So what they did was they trialed each patient with a stimulator for 2 weeks, which is similar to what you get in the regular outpatient setting. They had to show a 2 out of 10 point improvement to be included in the study. And then they were randomized from there. There were 4 3-month treatment segments. 2 of those periods, they got real burst stimulation. The other 2, they were getting placebo. And everyone was blinded to what was happening. The patient, the doctors treating them, the statisticians, everyone was blinded apart from the clinical trial nurse who set the stimulators. And their power analysis showed that they needed 50 participants. Mostly they were looking at ODI, which you remember, 0 points on the ODI is no disability, 100 points is max disability. And the minimal clinically important difference shown in previous stimulator trials is 10 points for this. And then they were also looking at leg and back pain, quality of life scales, and then using accelerometers to see how often patients were standing and walking during the day. Here's just showing that they included 50 patients, and nearly all of them were successfully randomized. And here you'll see kind of the main evidentiary table in that, looking at ODI, leg pain, back pain, quality of life, and their physical activity levels. There was no difference between when they were on periods of getting the burst stimulation and on periods where they were getting the placebo stimulation. So using patients as their own controls, no difference between the real stimulation and the placebo. And then here, I think a very important table, table 3 shows the adverse events related to the actual spinal cord stimulator placement. So 6% of them had a durotomy when it was placed, 4% needed a revision of the leads. There were 2 patients with infections, 1 needed a replacement, and then 1 had urinary issues. So not insignificant adverse events that occurred with these. So the overall conclusion of the study is that there's no difference in the change in baseline of ODI scores, leg pain, back pain, health-related quality of life, and physical activity levels between real burst stimulation and placebo stimulation. And the adverse events associated with a spinal cord stimulator are not insignificant. So this really goes to highlight the powerful placebo effect of these invasive neuromodulation techniques that we're using. And there's many weaknesses of these open label studies where patients are getting stimulators placed and they just think they're getting benefit from this placebo effect. So I think this is a great trial that really shows when you get down to it and use patients as their own controls, they can't tell the difference between their burst stimulation and their placebo. Questions, thoughts?
This is Jens in Seattle. Thank you for this great presentation. This is really an important article, and it's actually, it fulfills the science elements. When we have new technologies, we face a couple of problems. Number one, the technology always changes. It changes its presentation. It has a new iteration so that then any stratifications towards older technologies don't apply anymore. And secondly, they're usually applied in a very undifferentiated fashion. For instance, for patients where, quote, everything else has failed, so might as well try this. So this really applies a very important insight towards this. I thank you for this. Again, going back to the exclusions, this was a pretty broad and subjective thing, like patients where it doesn't apply. So in your critical analysis, was this a legitimately applied thing? I forgot how many patients were excluded, or did this allow the investigator some arbitrariness?
Well, there probably was some arbitrariness. They initially screened like 250 patients and they whittled it down to 50 based on those exclusion criteria, the majority of which were those excluded because they had previous procedures or were getting concomitant interventions that they didn't feel were appropriate. But there was some subjective screening of, we don't think this patient is right for the study.
Yeah, that was a great summary, Jim. I'm curious, Jens, in your practice, who are the folks that you're typically referring, or if any, based on this data for spinal cord stimulation?
Yeah, so I think this is a very meritorious technology, but this is where we have a disconnect to some of our interventional pain colleagues. Speaking as a surgeon, good morning, Ahmed, by the way, good to see you. So this is a genuine disconnect because I think for true neuropathic pain, this is a very legitimate situation. Also for some transition zone pain and spinal cord injury or incomplete spinal cord injury patients, I personally subjectively think that this has a real merit. And patients, by the way, this quadruple randomization, I got to look at that study again. I never quite understood what that was, and I didn't follow that up. I will follow that up later today because that had me fascinated. Patients can tell when they turn on their buzzer. My problem is, and I think this is, I may be speaking for you also, this is put on in an undifferentiated fashion without any kind of remote consideration for what the actual somatic pathology may be. And I see this on spinal stenosis patients. I see this on myofascial back pain patients, scoliosis patients. I mean, it's just like $28,000 plus just thrown at like a gum at a wall to see what sticks. I mean, it's just like undifferentiated stuff, a procedure that is, quote, low harm in the official diction. So that's my real problem. And I think, I assume I'm speaking for you also, the majority of those patients just have this stuff in there and sometimes an intrathecal pump in addition to that, and it literally does nothing.
Yeah, it's not uncommon that we see patients who have stenosis or spinal deformities who are, who have had, a spinal cord stimulator placed and pain pump placed before they see us. I have seen, at least, anecdotally in my practice, as you mentioned, Jens, patients with incomplete spinal cord injuries who have that kind of generalized neuropathic pain. Some of those patients seem to respond well to stimulator. Ahmed, any thoughts on it? Is there a patient population that you feel that benefits the most?
Yeah, similar to Dr. Chapman, I do feel that there is a role for spinal cord stimulators, and I don't think that they should be used willy-nilly, but I do think in the patient with true neuropathic pain and a well-decompressed spinal canal, that there is some benefit that people receive from these devices. But it's interesting to see that again in this study where again it's used probably in a more generalized fashion, and again we don't know the group that's being picked here is probably a wider group, and it may not be the group that we're thinking of. It may be a group that's a little bit more generalized than that. Again, these are patients that are probably coming to a pain practice that may include patients that we still think have stenosis that would be operable. We don't know that for sure, but or a canal that still has some degree of pathology. But I think if there's pathology, I don't think that the spinal cord stimulators work as well. So again, I reserve these devices for a well decompressed spinal canal in which there's still neuropathic pain that has been refractory to the medical treatments that we typically would use, such as neuropathic agents such as Lyrica or gabapentin, Cymbalta, these other medications that again are fairly well tolerated and often give a good result for the patient. So if those things aren't working and the patient is really struggling, then I would consider a spinal cord stimulator in those select group of patients. And they do have a place. They're not widely used in my practice, but they do have a place.
Yeah, I think that's the key is refractory neuropathic pain. I think a lot of these are being placed for patients with predominantly axial pain, and certainly there's not a lot of data even on the more favorable trials for spinal cord stimulator to support its use for axial pain. And so maybe that's where some of our other treatment options from a non-operative standpoint may come into play. And I think that might be a nice segue into our next article. I think, Brian, you've got the next one.
Yep. All right. Thanks, Jim. Let's see, just share my screen here. So I'm Brian. I'm one of the other Mayo Spine Fellows. All right. So I'm going to talk about a procedure, an interspinous spacer, which is sort of on the continuum of from non-operative treatment to sort of, something much more significant like a surgical procedure or a decompression. And so this is a technique that a lot of people have been using. And so we're going to kind of analyze the data a little bit. So this comes out of World Neurosurgery in 2017. And it's a kind of a conglomerate group of a lot of different people that are looking at the Superion interspinous spacer treatment of moderate spinal stenosis 4-year results. And their ultimate goal was to determine the 4-year clinical outcomes in patients with moderate lumbar stenosis treated with the Superion interspinous process device. So here's just sort of pictures from the website as well as from the instructional guide on how to use this thing. But it's essentially an interspinous spacer that prevents and blocks sort of intervertebral extension and prevents compression of the neural elements. So on the left, you can see this is just what it looks like. It fits in between the spinous processes. The middle picture is kind of the insertion point where you go through the supraspinous ligament and place it into a docking station right here in between the spinous process, and then kind of expand it and deploy it. And then you can see here are the x-rays of what it looks like once it's deployed. And so the study itself was, as I mentioned, as a 4-year study looking at the Superion data that was extracted from the original randomized control trial. It was the FDA, the IDE study from that period. The patients had neurogenic claudication symptoms that were relieved with back flexion, and these patients had failed 6 months of non-operative treatment. So the original IDE study was comparing the Superion, which is originally created by Vertiflex and then recently bought by Boston Scientific. And that was also compared to the X-Stop device, which was developed by Medtronic. As far as the inclusion criteria, as 45-year-old people with moderate symptoms of neurogenic claudication were secondary to degenerative lumbar stenosis at 1 or 2 levels. In terms of the moderate lumbar stenosis, that was defined as 25 to 50% reduction in lateral or central canal diameter compared to the adjacent levels. And they had radiographic evidence of either thecal sac or cauda equina compression, nerve root impingement, either by osseous or non-osseous elements, and or hypertrophic facets with canal encroachment. And in terms of the clinical symptoms that they wanted to include, these were patients that had Zurich claudication questionnaire, physical function greater than 2.0, and they were able to sit for 50 minutes without pain and walk greater than 50 feet. So sort of demonstrating their sort of moderate lumbar stenosis. In terms of exclusion criteria, there are quite a number because they wanted a very select group of patients. So lumbar stenosis at 3 or more levels excluded you. Any sort of spondylolisthesis grade 2 or greater. Unremitting low back pain that was not relieved in any position. Any elements of lumbar instability, so translation greater than 3 millimeters or any angulation greater than 5 degrees. Any active systemic disease or condition that may affect safety. Vertebral osteoporosis, a BMI greater than 40, any previous lumbar surgery, and then pregnancy or lactating female was an exclusion criteria. So the original trial was from 2008 to 2011 at 31 investigational sites and included 391 patients. 190 of them had the Superion and 201 had X-stop. And as I mentioned, the outcomes was the Zurich claudication questionnaire, symptom severity scores, physical function scores, patient satisfaction, the leg and back VAS, and they also measured the ODI. And in terms of the MCDI, the minimal clinical important difference, they used sort of the standards for the Zurich claudication questionnaire, as well as for the VAS and for ODI. So in terms of the patient population, there was 144 out of 90, so 75% had no reoperation, no revision, or supplemental fixation at the index levels in 4 years. 46 patients required reoperation, 41 required implant removal, 128 or 67% were free of reoperation or steroid injection at any level, at any level at 4 years. And at 4-year follow-up, 89, so 73% of the over total all patients completed the follow-up clinical outcome evaluation. So we'll go and get into their data just a little bit. So here's just a diagram showing a over time course, the Zurich claudication questionnaire, and at 84% demonstrated clinical success in 2 of the 3 domains. So that's the symptom severity, the physical function, or the patient satisfaction score. So you can see that by 4 years, you see a reduction in those. Here's the VAS leg and back pain. You can see as well similar reductions that were durable over that the 4-year time period, further demonstrating from their patient-reported outcomes that they're having good success. The ODI percentage, and you can see there's a reduction that continues all the way up to 4 years. Here's a percentage improvement of each of the outcomes. As you can see that there was a pretty significant amount across all the domains that they followed up with. And then they did what we call a within group effect size to compare to the baseline. And they used a size, it's basically a mean baseline minus the mean follow-up divided by the standard deviation. And they said that it was at all domains, there was a very large effect size within each group. So overall, the comparative results for these 3-year follow-up for Superion for all the outcomes, the within group effect size was greater than 1 from baseline, which they called a very large effect. Unfortunately, approximately 1/4 of patients underwent reoperation or removal, which they say that's kind of in line with their normal sort of data. And then in terms of minimally invasive implantation of this device provides long-term durable relief in patients with moderate lumbar stenosis is their overall conclusion. And they say that the interspinous spacer is an intermediate intervention on the continuum of care for patients with degenerative lumbar stenosis. So overall, I think it's a good study. It's looking at long-term outcomes of these interspinous devices, and could that be possibly something that we could use as an intermediary on that sort of scale of invasiveness for lumbar stenosis. So clearly, it's something that for a very select group of patients may be useful. All right. Any questions, comments?
Great summary, Brian. I think it brings up a couple interesting questions. I didn't see, so they had a 25% reoperation rate, but did they break out that subgroup for satisfaction and those types of things, patient-reported outcomes?
Not that I could see either. I didn't see any further data on looking at the ones that actually had a reoperation and what those were for.
And then I think there was, a interesting question from the chat group here. Control group or comparison to decompression alone. I don't think there was one in this study. Is that also correct, Brian?
That's correct. Yeah. So this was compared to essentially the X-stop. So nothing that actually compared to a surgical procedure such as decompression, which is certainly a shortcoming. But they're kind of demonstrating that this is different from a surgical procedure. But could it have the same outcomes? Not sure. So.
To our panelists, any thoughts? Is this a procedure that you're seeing done still in your community or in your practice, Jens?
So I'm actually, may surprise you there, I'm a fan of including certain interspinous spacers in our surgical armamentarium in the spectrum of what constitutes adult degenerative lumbar spinal stenosis. Somewhere between the purely stable and the unstable spondylolisthesis. There is a sweet spot of a yet to be defined kind of a dimension where, in my subjective experience, has been very beneficial. We were also participants in an FDA trial of a different device that provides a dynamic compressive effect in the back. And I see Todd Alleman on the visitors thing, so he'll have a smile on his face. I think you guys may have participated in that also. Without a doubt, there's a benefit to this. But again, we're talking about something that troubles me, and that is the mild to moderate stenosis indication. So this is, again, one of those gray zone things where an already gray zone procedure becomes really fuzzy. And I obviously believe the evidence, and we've just seen a very powerful study on the effects of placebo, but I don't know what mild or moderate stenosis actually means. I truly am far more binary there in terms of either you have a genuine stenosis or not. And as a surgeon, maybe to a flaw, I ignore those patients in terms of surgical considerations. I'll try to treat them non-surgically. And that actually usually works quite well. Can we prevent further surgeries if we put a smaller procedure in? Maybe, but again, as we see here, at least a quarter of those patients required further surgeries, which fits to my experience, 10 to 20%, that's what I tell my patients with certain interspinous process spacers that I apply in conjunction with a decompression will loosen or break over time. And that's a big deal. So what we're seeing again is this kind of fuzzing the marginal surgical indications by proceduralists. This is an outpatient procedure that can be done with a very small incision and without any surgical decompression. And this is again where I just question the genuine merit of it. So I'll shut up here, but I still have a major question mark about these kind of intermediate procedures like mild, MILD, where something is treated that in our world is not really a procedural surgical indication.
That's a great point you bring up. So along those lines, Ahmed, where do you sort of see the line? And I know this is obviously a little bit of a controversial topic, when something sort of enters the domain of needing to be managed by a surgeon versus a procedure that you think can be done safely sort of by a pain specialist.
I think it is controversial, and I agree with Jens that there's probably a sweet spot for some of these procedures, but I think often what we are finding is that some of these procedures are probably being utilized in patients that probably don't need surgery at all. Or alternatively, we're actually seeing patients that do need surgery probably having an intervention that's unlikely to give them relief, right? So we may see very severe stenosis that's likely going to end up needing surgery anyway, getting an intervention that's probably not going to then be beneficial. So an interspinous process spacer or a mild procedure being done for someone with very severe stenosis where it's unlikely to be successful. And so I think everyone's intentions are good. I think often our pain providers are thinking about things from the standpoint of, well, if I can do this small intervention and it provides benefit, then I've saved this person the morbidity of a larger intervention. I think the challenge is that, again, if we know that that intervention is likely not going to work, then we've just added cost and potential additional morbidity to that patient's care. So I often find myself, for example, taking out more interspinous process spacers in patients with very severe stenosis that had them placed, that probably it wasn't a great idea to put them in the first place, but they're often frail patients, and patients in which I think the thought process was, can we do something small to avoid a larger intervention? So I think that's the challenge, is trying to find that sweet spot and making sure that we're putting the right patient with the right procedure, which I think we still haven't figured that out exactly. So I think we're going to continue to struggle with that until we have a better coordination of care between ourselves and our pain providers, and a little bit more agreement on where's these interventions, where the actual sweet spot is for these interventions. But I do think there's probably a role. I don't exactly use these devices in my own practice, but I suspect that moderate group where you don't want to do a stabilization procedure like a fusion, as Dr. Chapman pointed out, where it's a spondylolisthesis. Maybe they have facets that are just on the border of what you would consider unstable, and you want something to stabilize that segment, but you don't want to fuse them. And maybe they're an older, slightly more frail patient, but you don't, again, want to do a fusion. Maybe there's a role for this interspinous device, and that's the right person where this device is going to be most beneficial, because they do also have a cost, and we have to kind of keep that in mind as well.
Yeah, all great points. And I think it would be interesting to sort of see a comparison between sort of our standard, one level decompression for this type of problem versus, interspinous spacer. I think we're kind of at the halfway point here. I think, Jim, did you have a question? I saw you have raised your hand.
No, apologies.
Oh, okay. Well, given that, I think you can lead us off into the next article if you want to take it away.
Excuse me, Sebastian, can I have some comments?
Yes, please.
I've been using these interspinous spacers with limited success. I think the indications, they are not very clear cut, but having said that, I think the grade 1 and maybe grade 2 spondy, they are the candidates. And it only offers some relief, because if you look at the mechanism, it increases the flexion. By increasing flexion, it increases the diameter of the interspinous foramen, and thereby relieves the compressive symptoms in the legs. But having said that, sooner or later, after a couple of years or so, the degenerative process catches up, and they need some, bigger procedure like decompression and stabilization, etc. But I think I found the value in those patients who are elderly, who have who are not fit for any kind of major surgery. This can be done on local anesthesia, and it does increase their symptom tolerance, and even though they are not fit for surgery, but they get on with this limited relief device, and it helps them to cope their daily activity and cope with their symptoms. So I think there is some place, but it's still not very well defined.
And so just to clarify, are you using just the device itself to provide indirect decompression? Or are you doing a direct decompression as well?
No, I use it, which provides indirect decompression. It is it's an interspinous spacer made of silicone. It comes from Italy, I've forgotten the name of the company, but you put it under local anesthesia, you dissect the interspinous or the base of the spinous area, and you put it with a sort of inserting device, and it expands a little bit, and that's it, what it does. You can see it on X-ray because there's some certain mark in there. And with that, I think it does relieve, symptom, as I said, that it opens up the spinal exit foramen, and it relieves the symptom, especially in the grade 1 and grade 2 spondy, and especially in those patients who are medically not very fit and they can't afford gen anesthesia, and they can afford the local anesthesia, and it works very well in those patients.
That's great to hear. I think it's helpful to get that experience from someone who's been putting them in, and so it's good to hear that you've seen good benefits to it in it sounds like a very select group of patients. Thank you for sharing that. Moving on, Dr. Bernanz, you want to take us away with the next study?
Yeah, terrific segue here, because I'll be talking about the mild procedure. So this is the MOTION study, which is a randomized controlled trial for lumbar spinal stenosis patients treated with this mild procedure. This was their 1-year results. This was published in the Journal of Pain Medicine. So for those who haven't heard of the mild procedure before, it's an acronym for minimally invasive lumbar decompression. That's a patented procedure by a specific group, the Vertos Medical Company. And if you Google it, you'll encounter their very impressive marketing campaign. It rivals like a new sports drink or something. They have podcasts, they have webinars, they have really impressive marketing online, which I was unfamiliar with. But this mild procedure in this study, they're comparing, and I'll go over the details of it, the mild procedure with what they deem to be conventional medical management, CMM as the study refers to it, for adults with lumbar spinal stenosis and neurogenic claudication. So this was a prospective, multi-center, including 19 sites, randomized study of patients age 50 to 80 with 3 months of what they deem to be symptomatic lumbar spinal stenosis and neurogenic claudication. Very minimal information about what they included as far as radiographic factors, about the amount of compression seen on imaging, about the amount of instability seen on imaging, or their symptoms they determined to be mild or moderate. Patients were randomized, obviously not blinded to their treatment, and patients either got conservative management with the mild procedure or they got conservative management alone. And one of the flaws of the study here certainly is that their conservative management was really site dependent, was really treating physician dependent. So at the same time as getting the mild procedure, they could also be getting epidural steroid injections, medial branch blocks, RFAs, facet injections. So not a clear control arm in this study. This is the mild procedure. These are the images from the actual paper. So it's done under local anesthesia with light sedation. You can see in the left image there's essentially a device that stops how deep you're penetrating with your instruments. So once you set a depth on X-ray, then you put that down on the patient's skin, which theoretically stops you from going any further and deeper and getting into the dura. But you can see on the right-hand side there, they're deploying what looks like a small kerosene and a small curette to remove a small portion of the lamina and preferentially resect and debulk the thickened ligamentum flavum. So they had 155 patients that were randomized in the study, half to the mild procedure, half to the control. And their results were pretty impressive. They showed that with the mild procedure, there was a 258% improvement in walking tolerance versus just 64% for conservative medical management. 16-point ODI improvement versus 2 points, 2.3-point improvement in their back pain, 3.6-point improvement in their leg pain, and only 6% needing a subsequent intervention over this 1-year time period, whereas 26% needed a subsequent intervention with just conservative medical management. They did not report any procedure-related adverse events with this. Here are the figures from the paper. The blue is showing with the mild procedure, the orange without the mild procedure. So you can see their improvement in their walking, in their standing, and their improvement in their pain and ODI scores here. So the conclusions of the study, that they wanted to get across was that the results of the mild procedure are durable at 1 year, that these patients had improved walking tolerance and overall had better pain in their legs and their back. Some limitations of the study, as we showed with previous ones, that this wasn't blinded, and certainly placebo can be powerful in these types of pain interventions. The conservative management here was pretty inconsistent, that they could also be getting concomitant procedures. So who knows if it was the RFA or the epidural steroid injection that they got that actually made them better. And this is 1 year follow-up data. Brian's had 4-year data, which would certainly be nice to see in a study like this. But certainly, as we've discussed here, this could be a reasonable options in patients who are not fit for a true surgical decompression, more mild end of symptoms. So I would consider this kind of just a one step up from an epidural steroid injection, somewhere between steroid injection and an interspinous process device. Questions?
Great presentation, Jim. I think you hit the high points. I think it'd be interesting to get MRIs on those patients sort of pre and post procedure. I know, as probably most of us are aware, when they first started talking about MIS decompressions, I think we had that kind of wonderful radiographic imaging to show us that you could still get a very nice decompression through a less invasive approach. And it'd be interesting to see how much decompression can be done using this technique. For our panelists, Dr. Chapman, are there European guys or anyone in your practice doing the mild procedure currently?
The short answer is no. We've seen it here in the lab. And again, there are a couple of things to point out. We're, again, talking about patients that maybe we've just ignored as surgeons and are far more kind of a binary approach of this is a surgical patient, this is not surgical. I conjecture to say that in the lectures I've seen here at our SSF place on this procedure, and that was included a recent STED talk, these are patients we would not consider as surgical. I'm fairly certain about that. And I also have to point out, having played with this in the lab, the imaging exposure of this is phenomenal. You have to basically use live fluoro extensively. And the control in terms of what you're actually doing with your effector tools is minimal. The disposable cost is fantastic. It's, again, dramatic what you're throwing away there every procedure. So this is, again, something where I want to be objective as a surgeon. I want to give credence to colleagues who are trying different approaches. But practically speaking, this is, again, something that fulfills me with great shrugs. I need to look at this article. This was referenced recently in our STED Talk speaker, and I didn't look that up again. But the first thing I always look at in these kind of procedures is how many of these authors actually have a financial interest or are truly disinterested. And the thing that this article clearly points out is the lack of a structured, well-performed non-surgical care. And I think a really important thing for all of us as spine surgeons is to be far more engaged in non-surgical care of patients and not just send them off to PT or injections, but identify a well-structured non-surgical care program that makes sense and that kind of addresses patients' needs. And that's, I think, what the originators of this technique are kind of aiming at, the, quote, neglected patients where they're just kind of left hanging. They didn't garner the interest of the surgeons, and they are then floating around somewhere in space.
No,
I would echo a lot of these. Yeah, sorry. I would echo a lot of these same points. I've had we have several providers that do this procedure at our institution, and obviously we don't see the successes. We only see the failures as the surgeons. So we only see the patients that get referred on to us after the procedure has not worked. And so obviously we have a very skewed view of that. In those patients, we then have the advantage of getting imaging after the decompression. And so in those patients, I have not seen much of an effect of the mild procedure in terms of pre and post mild procedure MRIs. It really looks almost identical. And so I'm a skeptic at this point, but that doesn't mean that the procedure can't keep getting better. But it also slightly terrifies me that you're putting a kerosene into a canal blindly. So again, a little bit of a skeptic at this point. thinking to myself, again, how much are we really doing here? But this is the first paper that I've actually seen 1 year data. I think the paper itself is quite flawed, and for a lot of the reasons Dr. Burnat's pointed out, which is control group is not great. And what we've figured out from the vertebroplasty data, as well as the kyphoplasty data, is the power of placebo, right? So the more drastic the intervention is, and the more drastic the placebo is, the more drastic the placebo effect. So for example, if you open up cement in the room and you take a needle and you push on the patient's back and you make them feel like they're getting a vertebroplasty, you don't actually have to inject any cement in their back. They actually feel amazing, and they get up from that, bed, and they actually say, my fracture feels better, and they never actually got cement in their back, right? So we know that there is the power of a placebo effect potentially in a vertebroplasty, and that's when they really have a fracture. So I'm not saying that vertebroplasty doesn't work or kyphoplasty doesn't work. We know that it does, but that's the power of a placebo effect, even in that patient where we know there's real pathology that could be treated. But that's the power of a very fancy placebo. So when you're not doing that, but you are, doing an actual intervention, but the other side is not getting it, you can again have a very, very powerful placebo effect. And so I'm not discounting the fact that this is actually working, but I am wondering, again, if these are patients that don't have severe stenosis, but now think that they've had this incredible new procedure, they may actually continue to have benefit from that, believing that they've had the newest and greatest thing. And so I'm not discounting this, but I think we do need better studies if we're actually going to really put a significant weight in this, because it is a costly procedure. It's not a cheap procedure that they're getting.
Yeah, and I think those are all great comments. I think the other thing, is understanding what, having talked to our pain providers who do this procedure, really this should be a patient who has predominantly ligamentous overgrowth causing sort of more central lateral recess stenosis. This shouldn't be the patient who has a lot of facetogenic overgrowth, because obviously those patients, we're not tackling any of their stenosis. The idea being that these patients who have more central ligamentous overgrowth, by sort of shaving the ligamentum down, but not actually taking all of it out, it may thin it out enough to give the patient some relief. So I think, my understanding, again, talking to our pain guys who I think do it in a fairly thoughtful way, is that we really want to be selecting for that patient population if we're going to be doing it.
Dr. Sebastian, have you seen dural tears when you've had to revise mild procedures? Because that is what I have seen. And again, during the procedure, they may or may not be aware of that. Again, this is done under contrasted fluoroscopy only. But afterwards, they just have this area that's kind of been abraded, I think, from the circular current action. So I've had to revise a couple of those patients, and they've had kind of persistent radiculopathy. This may have just been anecdotal, but again, with no real layering against the dural sac, this is something that I think is technique inherent. And as we see more practitioners delve into this with less differentiated training, this may be more common.
Yeah, I think that's a great comment. I've revised a couple of them. I can say from the ones that I've revised that were referred to me by our pain providers, I have not. I think they're pretty judicious in how they approach it. But I have seen a few outside where they do have this kind of central dural tear right at the level of the mild procedure. Thankfully, those are fairly straightforward to fix. But no, I have seen that once before. Ahmed, have you seen that with the mild procedure?
Again, most of ours have come internally. I haven't had any dural tears. I've had some scar tissue in the epidural plane that was a little harder to take out, but nothing, fortunately, so far that's been specifically like a dural tear that I've had to fix as a result. But I think, again, our providers have been very cautious. So maybe we've just been lucky that we haven't encountered that yet. But I suspect that we will see it in this procedure, just because, again, it is being done blind. So
all great comments, and obviously a lot of stuff for us to think about. I think moving to our last talk to talk a little bit about maybe some treatments for axial pain. Brian, you want us to take us away?
All right, great. So we'll round out our discussion with the last article, which has kind of been the bane of our patients, and that, you know, axial back pain is difficult to treat, and it's hard for us to take care of as well. So this is a paper coming out of the Spine Journal in 2019. It's a prospective randomized multicenter study analyzing intraosseous basivertebral nerve ablation for the treatment of chronic low back pain. And this is from the Intercept Trial investigators. So just talking a little bit about the basivertebral nerve. So there's a bit of basic science evidence to suggest that the vertebral end plates act as a significant mediator of low back pain. And the basivertebral nerve, which is a branch of the sinovertebral nerve, mediates the vertebrogenic pain. And here you can see on this diagram the sinovertebral nerve and how it kind of innervates through the basivertebral nerve to the end plates of the vertebral bodies. And so the actual procedure itself is essentially a cannulation. This is taken from Relievant's website, but looking at how the cannulation of this RF ablation probe goes through the pedicle, goes into the middle of the vertebral body, and then provides an ablation that I'll discuss in a little bit more detail in the methods. But overall, their objective was to compare the effectiveness of the intraosseous RF ablation of the basivertebral nerve as compared to conservative management. So as I mentioned before, is the Intercept Trial, which is sponsored by Relievant Medisystems, is a prospective open-label randomized control trial that was conducted from 2017 to 2019 over 20 institutional sites. It included overall 140 patients with one-to-one block randomization, either to the basivertebral nerve ablation or a continuation of standard of care. And the primary endpoint for this study was 3 months follow-up, and there has been subsequent follow-up later on as well. Inclusion criteria were skeletally mature patients with greater than 6 months of chronic low back pain with no response to the conservative management of either, and they had to have type 1 or type 2 modic changes in the L3 to S1 vertebral body areas. They also needed a minimum VAS of 4 and an ODI of 30. In terms of exclusion criteria, as we've seen before in many of our studies, you can see that there's a very vast number of exclusion criteria. So I won't go through all of these, but most of them are that, you know, if there were changes in other areas of the spine, radicular patterns of pain or symptoms, any sort of metabolic disease, spine fragility fracture, spine trauma, spine cancer, and then any radiographic evidence of other pain etiology. So that's a disc extrusion, protrusion greater than 5 millimeters, spondylolisthesis, or signs of instability, spondylolysis, facet arthrosis, and then any compensated injury or other litigation, a BMI greater than 40. And then lastly, they said bedbound or neurologic condition that prevents early mobility or any medical condition that impaired follow-up. So kind of a loose exclusion criteria. In terms of the overall treatment, so it's a unilateral transpedicular RF ablation of the basivertebral nerve, as I mentioned. They were allowed to do up to 4 vertebrae from L3 to S1 under either conscious sedation or general anesthesia. In terms of the actual target zone, it's about 30 to 50% of the sagittal width of the vertebral body. So if you look on the center image here, you can see a lateral radiograph, and that's kind of the target zone that they aimed for. And it was a thermal ablation of 85 degrees centigrade for 15 minutes to create a 1 centimeter lesion. And so on the right side, you can see a follow-up MRI, and that's what the actual ablation looks like. In terms of the standard of care cohort, they were allowed to have pain medication, physical therapy, exercise, chiropractic treatment, acupuncture, or spinal injections, essentially the continuation of supportive care. Here's a sort of flow diagram. I apologize, it's a little bit hard to see, but you can see that there was 420 patients analyzed, and then several were, nearly half were excluded. And then in terms of analysis, all the way at the bottom, you can see there's 51 that were allocated to the RF ablation treatment. And then on the supportive cohort, there were 53 patients. This is another busy table, but this is essentially a table demonstrating that there was no differences in terms of demographic between the RF ablation or the standard of care patients. And in terms of their outcome measures at 3 months, so they looked at the patient-reported outcomes of ODI, low back VAS, the SF36, EQ5D, and then they obviously looked at adverse events. They performed an interim analysis at 3 months, which showed statistical superiority in all outcomes that were favoring the RF ablation. And so the data management team, which is an independent group, actually recommended that they halt the trial, halt the control arm and offer supportive care patients the opportunity to actually cross over to the RF ablation because there was such statistical superiority in all outcomes for the ablation. And so, as I mentioned, the RF ablation was completed in 51 patients, and that was most commonly done 47% at the L5S1. Here you can see this is sort of their beginning of their results. Mean reduction in ODI, looking at the RF ablation versus the standard care on the right. So they had a ODI difference of greater than 20 points. And if you looked at sort of thresholds, if a greater than 10-point reduction in ODI, there was almost 74%, 75% with ablation as compared to 32%. And then looking at if even more significant, greater than 20 at the bottom, reduction in ODI, you can see there was 62% of patients had a reduction. Looking at the VAS, you can see there was a difference of 2.4 between the RF ablation and the standard of care. And again, using sort of thresholds of 1.5, you can see that was almost 74% had an improvement, and at greater than 2 centimeters for the VAS, there was a 72% improvement. And then looking at kind of the other patient-reported outcomes that they looked at, so the SF36 physical component summary, you can see in the red boxes here, there was a difference between 11.9 between the RF ablation and the standard of care. And then looking at the mental component summary, there was also an improvement of 5.4. And then looking at the EQ5D, there was also a difference. These are all statistically significant between the RF ablation and the standard of care. So overall, 78% of the RF ablation patients stated that their condition was improved. 16% said that there was no change, and 6% said that they actually had a worse condition. 80% of patients said that they would have the procedure again, and 88% said that they would recommend the procedure to another person. In terms of adverse events, there were 22 in total. 13 were in the RF ablation, and all were categorized as mild with no intervention except sort of oral medication at most. There were 3 were general procedure related, 7 were specific to the procedure itself. So some indications are such as low back pain and enucleation or paresthesias. Overall, they said that there were no broken devices, no pedicle fractures, and no infections. So overall, I think it's a great study. It's a large randomized controlled trial directly comparing the RF ablation of the base of vertebral nerve as compared to the current conservative management. However, it does lack comparison to other procedures or surgical treatments of low back pain, similar to kind of what was discussed in the previous article, that the control may be a little bit difficult to analyze and interpret. The patients overall that were treated with the ablation exhibited significant improvement in the patient-reported outcomes. This is the initial results that were published at 3 months. There have subsequently been 12-month follow-up and 24-month follow-up, and all of them have demonstrated similar improvements that have been durable with the BVN ablation. And the authors overall conclude that while these studies do not suggest that the BVN ablation is a better treatment for all patients, it does appear to be a highly effective treatment for a select group of patients with the chronic low back pain. So as we mentioned before, with a lot of these studies, the control and the patient selection is the most important part of all of this. And so BVN RF ablation may play a role in our treatment armamentarium. Any questions? Yeah, Dr. Chapman.
Yeah, thank you for presenting this article, and that was a nice summary indeed. So This is a very interesting concept, and we as spine surgical community have overlooked the basivertebral nerve clearly over time. And my understanding is and was that with Shane Tubbs having been here for many years, the famous neuroanatomist, this served as a baryceptor kind of a nerve. So when we pressure our spinal column, it basically creates a venous shutdown so we can kind of pressurize our vertebral bodies against impact. So that's the purpose of this nervous system, as I understand it from Shane Tubbs. I am still confused about this because my good friend Bernhard Meyer from Munich, who's one of our faculty at our annual spine oncology course, is one of the senior authors of a comparison study with 2-year results. They had a double-blind, sham-controlled multi-center study on the same kind of a technology. I'm just looking at the article. Jeff Fishkin was actually the first author. Rick Sasser's in it, Scott Kitchell, Hyun Bae. It's a remarkable group. They could identify a benefit, but they had, again, a surgical sham group, and they had a substantial improvement as well in that. They said there was something to it in certain patients, but they couldn't quite identify who it was. They did have a group with discography. They did not address modic changes, for instance. So there's still a lot of big question marks. But the craziest thing was that the patients who had, again, a cannulation of their pedicles done, but nothing actually electric took place, had a pretty substantial improvement as well. So I'm just reviewing this, and this was it's not a great journal, International Journal of Spine Surgery, but it's 2019. So did you look at that also, and what are your thoughts in terms of how to identify a sham procedure relative to a radiofrequency ablation procedure still having had substantial improvements?
Yeah, that's a great question. That's kind of the question we all have with any type of RFA procedure. I know for facet joints, we don't really have a lot of people doing the Intercept procedure yet here, but for the radiofrequency ablation for the facet joints, one of the things that they'll do is trial a diagnostic injection. I saw someone mention that in the chat box. And if they don't have a benefit or a positive response to diagnostic injection, they won't proceed with an ablation. But I think, again, as has come up, I think several times in the articles today, the placebo effect is powerful and probably underestimated. Ahmed, any final thoughts here? Dr. Nasser may have had to step out. I'm not sure. Yeah, so anybody doing the Intercept procedure then at your facility, Dr. Chapman?
Yeah, so we have not started that here because, again, this is one of those very expensive treatments if you look at the financial planning from the company, and this has not become validated enough to allow for most commercial insurances or the federal government to actually remunerate that adequately. So this, again, remains in balance, and that's probably a meritorious factor. Again, my good friend Bernhard Meyer, with whom I talk pretty regularly, still says, I don't know what we actually saw here. He really believes that there's something to it, but he doesn't know how to quantify that. And for me, when they designed the study, and these were very good people, the simplest thing that I would have liked to see is there a modic change type 1 or type 2 present, which I counter to most people still think has some correlation to back pain. The role of discography here should not play a role, yet that was kind of used in some of those patients as a diagnostic tool. And again, if you believe that there's an intraosseous kind of a sensitization with so-called C fibers and this nerve bundle that goes into that basivertebral system becoming activated, then that's so nociceptor fibers developing, then that's a very different pathway. So it's a remarkable discovery that we have an innovation that's intraosseous that can turn into a pain system. There's probably truth to that, but how to actually activate that clinically, I have no clue about. And Bernhard Meyer himself says he doesn't know. I got to talk to Rick Sasso about that and Jeff Fishkin. We have a conference call about something else coming up, and so I'm going to ask them what they think now, because they were co-authors on that same study.
Yeah, I think that those are all good points. I think there's a lot more to learn, and hopefully, some of these axial pain patients that we don't have a lot of options for, maybe some of these treatments will represent, some revolution in how we manage axial back pain. So with that, I think our time is up. I want to thank Dr. Chapman and the Seattle Science Group for inviting us again to host Journal Club, and thank both of our fellows as well as Dr. Nasser for participating today. It's been an interesting and hopefully helpful discussion for everybody.
This is a super topic. Thank you so much. And thank you to Doctors Go and Bernatz for selecting these articles and presenting them so well. And we need to be far more engaged in this discussion. So you've led the charge here. Thank you so much.
Thank you, everyone.
Thank you.